morning. My name is Pam Coons. I'm one of the GI medical oncologists. It's my pleasure to introduce Dr. George Fakhri for today's YCC Grand Round speaker. I'm going to do a brief introduction. I promised him I wouldn't. He has so many publications and awards, but I won't read all of them. So Dr. Fakhri is the Elizabeth Mears and House Jameson Professor of Radiology and Biomedical Engineering and of Biomedical Informatics and Data Science at Yale School of Medicine. He has been here almost exactly 1 year. Last year, October 1st was his anniversary. He also serves as the Vice Chair for Scientific Research in Radiology and the Director of the Yale PET Center. He has a PhD in medical physics, an MS in biomedical engineering from the Paris Sud University, and an MS in electrical and computer engineering from the University of Texas at Austin, and a master's of engineering from École Centrale in France, and I probably mispronounced that. But he is internationally recognized in quantitative molecular imaging for in vivo assessment of pathophysiology in brain, cardiac, and oncologic disease. His current areas of research include high-resolution PET-MR imaging in a range of diseases, including neurodegenerative disease, traumatic brain injury, cardiac disease, and oncology. It's really a pleasure to partner with him as we think about PET imaging and oncology, my area of expertise in neuroendocrine tumors, and as we think about really bringing some of his expertise to clinic. So thank you so much for joining us today.
Thank you very much, Pam, for the kind introduction. I was reminded it's almost a year. I've been using 9 months as an excuse that I'm not ready yet, but I guess that's run out now. So it's a pleasure to be here and to share with you some of what PET and MR can do for you. Part of my job coming in here was to go below the neck because the PET Center is world-renowned in neuroscience. And we hope that I'll give you a taste of what you can be doing with PET and with MR in a center near you. So I'd like to acknowledge our funding that comes mostly from the NIH. And I would like to give a shout out to not only the PET Center that you see in this slide, but also the imaging group at Yale. That was from Friday, where we had our first mini retreat. And they're a PET Center, there's an MR Center, there's an image processing group, over 200 faculty and postdocs that do anything that has to do with PET, MR, or optical in all parts of the brain. If you are interested in any of the imaging, all what I'll be showing today is available today at Yale. Some of it may be about to start because 11 months is a short time, but for the most part, it's all available now as a revenue neutral course. So please give me a line if you're interested in any of this. This is the core I'm referring to. So we do everything from mice to men, including some animals you may not recognize. Many of you are users of the core. I'm not going to go through all the animals, but there's a woodchuck there and a rabbit. Some of you are actually users of the core. You are in many departments, and we do everything from cell culture to phase 1 in the core. So I'd like to start with a quick slide about maybe that's one of the very few about modalities, talking about PET and MR, to highlight that these two modalities are quite symbiotic in that PET is a very high sensitivity modality where we image picomolar concentrations. You'll hear me often during the talk today talk about measurements that are at the cellular level, something we cannot do with MR. We are nowhere near the picomolar or the nanomolar really in MR. But in PET, we have a very poor resolution and everything is relative. I hope by the end of the talk, I will convince you that's not anymore the case because you'll see images with a 1 millimeter resolution in PET. But for all intents and purposes, our scanners today are in the 4 or 5 millimeter resolution, whereas in MR, our resolution is exquisite. We can form many images in a very short time without any ionization. Quantitation is challenging in MR, and that's what we do on a daily basis in PET. So you can see that the strength of PET and MR are really the weaknesses of the other modality. And what I'm going to try to show you today is putting those together, there are a lot of things we can do in cancer that get us to the heart of many diseases. I will try to show this by body part in the spirit of a grand rounds, but you'll see that a lot of those, there's symbiosis between the two. Our efforts are part of actually a center of excellence that is one of 20 in the country. This is the one in Paramar. This is the only one in Paramar in the nation. And there's several pieces we are supposed to be doing in this center. One of them is developing new targets, and I'll show you some of the radiochemistry for some of these targets, the ones that are in cancer. But there are also a whole component in terms of image analysis and processing, and in terms of dissemination. And I mentioned this because it is part of our job to disseminate our work to as many users who are interested as possible, provided they're NIH users per NIH rules, but actually we often break that rule and we work with everyone. So if you are interested in any of this, please do let me know and we can discuss afterwards. So I thought I would start in the head because, well, it's the highest up, and as I mentioned, we do a lot of work's being done in the brain. And I would like to, I don't know if we're supposed to be monitoring the chat. Oh, this is for you guys. If you want to have CME attendance, please text 46793. I think from here on out, we won't look at the chat until the end. So I'd like to start with some work in MR spectroscopy, actually. And this is a nice success story because there's been a lot of work going in my lab in this area led by Chao Ma. And there's a lot of work happening here at Yale in spectroscopy that I'll feature some of, and you'll see how the two come together in terms of imaging. The basic idea is that for a long time, what we have done in spectroscopy is looking at a voxel. So if you knew where to look, you'll get a good answer. And what you would hear often is spectroscopy has good potential, but it was never something that is done routinely in the clinic. I hope today I'll convince you that now there's quite a bit that you can do in the clinic without a major burden for your workflow. This is just to show you that the trick in what I'll be showing you in terms of imaging is not to image the whole space, but to only image what we're interested in terms of metabolites, because that allows us then in our reconstruction of the image to go much faster. And instead of having, a one scan or one voxel, to have a quantitative T1, T2, and myelin water fraction, and everything else you're interested in a time that is very reasonable for MR, about 8 minutes, but with a resolution that is very good. We're talking about, 1 by 1 by 2 millimeters, or 2 by 2 by 3 millimeters. And from that, we can estimate then all of the different metabolites looking at. We're showing you here choline, creatinine, CAA, glutamate, glutamine. I will have very few images in normal subjects, only just to make a case. I know this is a cancer round, but this is one of them. And now we look at a brain tumor, and you can see that now the value of having a whole image of spectroscopy as opposed to a whole voxel of spectroscopy is that now we can assess in the entire brain the different signatures of the tumor rim, the necrotic component, and the edema, which have different signatures. We can push this further and look at, actually, this is a little longer now. It's 12 minutes, but you can see here that the signature on the different metabolic components, for example, the lactate and the choline, are very different for the same tumor. And that allows you to start having some insight into, what is the hypoxic component, what is the 2HD or the IDH mutation for that glioma in this case. And then this is on the MR spectroscopy side. We can also add the PET. Just one more slide to show you that this is not just a pretty image. What I'm showing you here is on top is the clinical T1 weighted and FLAIR T2. In the mid row is the quantitative T1, T2 maps. And in the bottom are the NAA, choline, lactate. It's not just a pretty image. You can see that the discrimination we have, and this is the manual annotation by the neuroradiologist. You see the discrimination between the edema and the tumor is done much better when you have access to your metabolic images from MRSI than it is when you have access only to your clinical MR. It is not as different when you're looking at the lesion versus normal. There, it's pretty clear. I want you to look at the green curve and the blue curve. These are the receiving operating characteristics, so the REC curves for what is true. And you can see that we do a lot better when we have the MRS information compared to when we have only the MR information. And next, we're going to look also at, we can add the PET, and we can see that in this case, we're looking at an amino acid, the fluoroethyl tyrosine, in addition to the MRSI. And I hope you can see where I'm going with this. The idea is that now we can see on the T2 FLAIR, well, the entire tumor plus edema. You can see on spectroscopy the areas that are, this is a low-grade glioma. You can see the areas that are more involved in terms of metabolism. And then you can see from the FET, the subset of that tumor, that is the more aggressive component. And that, can be one way to look at image-guided radiotherapy based on the biology as opposed to a hunch. And you can see on the right side the signature of these, which are on the MRSI, which are different. This is all done with this is work done by Chao Ma and a grant he just started with proton. And now we can do also deuteron. This is the work of Hank Fader and Robin de Graaf here at Yale, where now we're looking at the deuterium metabolic imaging. So we're not looking at the H1 now, we're looking at the H2 here. Just that number changes, but a lot of things go with that. And we can look now at a 3D map of the glucose deuterium metabolic imaging, of the glutamate, glutamine, all of those in a human 4T scanner. This is again, this is now a little larger voxel. Now we're talking about a 2 centimeter isotropic in a 30-minute. But remember, this is now deuterium that we're imaging, not proton water. So signal is definitely less. The way we do this is no different than what you're used to with glucose FDG. You would, instead of having an IV injection, you would drink some glucose, wait for 75 minutes, and then your image for 45 minutes. Here's some of the typical image you would see. This is one of series of 23 patients with brain tumors that have been imaged now by Hank, where you could interleave your MR with your deuterium metabolic imaging, so you'd have both about the same time. It's a 45-minute protocol, so it's still a little long, but it's not impossible to do. And I'd like to draw your attention to the bottom, where not only you can see the glutamine lactate, but the ratio of lactate to glutamine is actually an indicator of the Warburg effect, and that is indicative of the aggressiveness of the primary tumor. So we are getting now more of a window into the functionality of that tumor as opposed to only the appearance that we have from the T2. Last slide on MRSI is to show you that we can also look at the choline metabolism in these brain tumors. As you know, choline is a precursor to acetylcholine, a neurotransmitter in the brain, but it's also a key component of the biomembrane. And the choline transport and the metabolism is regulated. It's upregulated in many cancers, so especially brain tumors. So the idea here is that you can have it either IV or you can drink it. And in both cases, you can see that 75 minutes later, you have a signal that is now the area of choline metabolism in the brain. So, and this is now without an amino acid PET injection. So you see that there's a lot of duality here in what we're doing, and doing one or the other allows you to see more. Now, I hope you've noticed that the images I've shown you of the brain were very poor quality. If you didn't, you're very polite, but these are the kind of images that we're all used to seeing in PET. Those are images at a resolution of about 4 millimeters, 5 millimeters. So for a volume, that would be 125 millimeter cubed. What I'm going to show you next are images now at 2 millimeters or 1.5 millimeters. So, something around 6 millimeter cubed. So about 25 times a better spatial resolution. This is a new brain system, a NeuroExplorer that has just been installed at Yale, funded by a UO1 led by Rich Carson at Yale and United Imaging Health in Houston. And the idea here is to go with a very small crystal with a very large coverage of the brain, very unusual to what we do today. This is about 50 centimeters of axial coverage. And the reason is we would like to get the highest sensitivity possible. And I'll show you some clinical implications or benefits of that. You can think of that both in terms of, well, you could inject a lot less, but also in terms of you can see signal in the marginal lesion detectability, what we call marginal lesion detectability. Those tumors that are the hardest to see because the contrast to background is the lowest. And now you can start seeing things we're not used to seeing. And I'll show you some examples of both. So I'm going to start with maybe the second slide of a normal, no cancer, but to drive the message of what high resolution and sensitivity buys you. So for those who are fans of astronomy, think of the HRT, which has been the best system we've had as the Hubble telescope. And that is still much better than a regular brain scanner. Those images actually are better than the ones you see in the clinic. And this is the NeuroExplorer, which think of it as maybe the Webb telescope. And here you have a 25-fold better image resolution and 20-fold sensitivity. So now we're starting to see cortical ribbon. We're starting to see central brain structures. We're seeing the horn of the caudate nucleus, the basal ganglia, things that until now we know about in neuroanatomy, but in PET we don't usually see. So what does that do to us in oncology? So here's an example of another brain tumor that is, again, well characterized on FLAIR. But what I would like to show you is the FDG scan of that patient, both on a clinical scanner and on the NeuroExplorer. And I do hope, yes, I can see it. I hope you see it over there. Can you see my cursor when I'm moving over there? You can, oh, good. Because usually by the end of the talk is when the speaker asks, can you see my cursor? So at least I asked only 21 slides into my 700 slides. So I hope you can see the lesion here. And unless you're really, really good, I don't think you can see it here. That's a good example of what a gain in sensitivity buys you when imaging with PET. All right. So we're going to move to sarcomas. And here I'm going to try to show you some examples of what PET and MR spectroscopy can do together. You're starting to see a theme. This started with a grant we were working on, where basically we had asked the question for many of the sarcomas for many of the patients who refuse to have surgery. We do have about 30% of patients who say, I want to forgo surgery because I want to go back to work less than a year later. There is a risk of recurrence. And so there are two questions. The first one, well, can we tell if we've treated everything or not? And two, if there is recurrence, are you able to tell early enough? And the answer to those two is yes. I hope I'll be able to convince you of that. Just know that from the radiation oncology side, and there's no critique by no mean, the current consensus is quite crude. Basically, it's you take a 3.5 centimeter longitudinal, 1.5 centimeter radial, you blast that, and you're good. And the question is, well, is that really necessary? And again, this is not at all, we work very, very closely with many of our radiation oncologists. This is not at all by any mean a criticism, but these are what we call gross target volume. So that's what we've decided is the tumor that was delineated by multiple radiation oncologists and maybe a couple of residents. And the message we're trying to convey here is that depending on who's doing what at what time of the day, your contour will vary. So don't hope for a very reproducible treatment that you would have the same way if two physicians did the same. And the message from that is not, oh, you shouldn't do it. The message of that is there a way we could reduce that variability? And I'll show you that, yes, we can. All right, so let's start with the first question. So here's one example. This is a 60-year-old female with a soft tissue sarcoma of the right leg. This is your T2 enhanced MR. So based on that, all of this would be treated because some of it is tumor, some of it is edema. We don't know what is what. This is your PET signature. We see that it's mainly this area that is actually active and the rest is not. Oh, somebody's trying to do something else while listening. And of course, on pathology that is confirmed, this is the area that is the tumor, and on a pathology, it's that's confirmed. Now, don't take my word for it. If this was my grandmother, I would say no, treat the whole thing. But doing this enough times, now we've seen that every time, what you see on FDG is what you see on pathology. So yes, you could use PET to guide your treatment. And the second question was, well, after treatment now, can PET help me with determining if there is any remaining? And the answer is no. Because yes, in this case, for example, you see there is signal here, but we don't know if this is tumor or if this is simply inflammation post-treatment. MR spectroscopy, on the other hand, can help you. So here's an example, that same example, where this is the healthy contralateral leg, where you see the choline-creatinine ratio is normal. This is the tumor, where you see that the choline-creatinine ratio is overtly abnormal. And in that area, you didn't know what to do with PET. Well, the ratio is normal, and sure enough, a month later, that has resolved. So you see that using both has a value, because the PET can guide you, but I can't tell you in this case whether it's a remaining tumor or not, and MR spectroscopy can. Now, this was easier said than done. What we actually did, this is the ugly part of it, is in order to map absolutely and be absolutely sure what is where, I showed you, oh, look, this is the PET, and pathology agrees. What we did really was we did an MR, we did a 3D printing of the tumor and of its surrounding. When the tumor was excised, it was taken in and frozen in this mold. Then it was sliced. We had to pay a lot of chocolate and champagne and drinks for the pathologist who agreed to do not 2 slides, but 40 slides out of 1 slice. And now you have your pathology and your PET absolutely in the same reference. And now you have a validation slide by slide. This is very important, because if we're going to do any deep learning, we need that. And I'll show you some of what we've done with this. It is very hard, very lengthy, but there is no shortcuts if you really want to do this the right way. Remember, I showed you a slide of big variability in the GTV. We have been working on this not to replace the radiation oncologist, but to provide the radiation oncologist with a starting point so they save time. In the US, we have radiation oncologists who are specialized in head and neck, in sarcomas, in CNS. In many parts of the world, and including Germany, France, China, many other countries, they do all parts, all body parts. So when you're starting, it's really nice to have something that can be a place you can start from and adjust. It saves you time. It increases your productivity. And it's a good training tool. So the idea here was not to learn from what one radiation oncologist can draw in terms of gross target volume or clinical target volume, but to have many of them do the same thing and have the neural network learn from all of those, as opposed to learning from one contour. This is a lot harder, because now you don't have a truth. You have more of a level of confidence based on where they agree. It takes a lot longer to learn. You need more data. And you're not going to be as accurate as if you had one radiation oncologist, because what you're learning is the variability. However, that will allow you to be a lot more robust, meaning if you go to a different hospital, if you go to a different setting, you'll still be fine, because what you've learned is a confidence level as opposed to a black and white. So instead of having one contour, what you will have at the end, what I'm showing you here, is a confidence level. So let me show you some results of how well we do with this. These are patients that were never presented to the network until validation, where you can see that there's a very good agreement between what the consensus between the radiation oncologists is, or I should say therapeutic radiologist at Yale, and what the level of confidence you have from the network. The yellower, the hotter, and the orangier, the less. I should have picked different colors, I guess. And you see that the accuracy is not, very good. It's in the 86%, which is where we expected. It's not 99%. And frankly, I don't believe in a network that does 99%, because you take it to a different location, it won't do as well. However, we are capturing very well the inter-observer variability, and from the CT, the clinical target volume, we're doing also very well compared to what was predicted. This is an example showing you now that if you did that, instead of doing it only on CT, if you did it with PET, you reduce your variability, you increase your reproducibility, which is what you would expect. And this is showing you that, we can do this now in a more sophisticated way with diffusion networks, but the resolution is about the same. We're still in the 88%. It's just that we're now more resilient to noise. All right, this is showing you that we can do this also for the clinical target volume, not just for the gross target volume. I'd like to move now to head and neck. We're excited that we're starting a new project now looking at this in head and neck as opposed to sarcomas, where we're looking again, how is the contribution from PET, CT, or taken together, and how well can we do? I hope you can see here that we can delineate very accurately the tumor. And more importantly, I want to show you what you can do now if you have a much better sensitivity with your PET scan, again, compared to what we're used to. So those are the same Webb telescope images. Now this is the work of Takuya Torinaga in our group, who is looking at head and neck cancer with the NeuroExplorer. So much higher sensitivity, much higher resolution, same patient scanned on our clinical vision and our research for now NeuroExplorer, which is FDA approved, by the way. Some of those are very obvious. You see the lesion very well in both. What I would like you to notice is, one, that the lesion delineation is clearer and the contrast is higher. That is not a higher glycolytic rate of the tumor. It's exactly the same tumor. It's just that we have less partial volume effect. That's all. These are lymph nodes in the left neck, where you see same story. And in the base of the tongue, same story again, where you have a much better delineation of the anatomy and of the tumor. This is a lymph node in the left neck. And I think I have one, yeah, this one I like. And this is, again, lymph node, left neck. But what I draw your attention is to this component of the tumor, which is barely visible and clearly visible on the NeuroExplorer. Okay. I think you've seen enough good pictures. Let's move to the next, some basic science. Now we're going to move to more basic science in terms of a new target. What we're looking here at is measuring the membrane potential. And you can think of the membrane potential as the battery of life for the cell, because that's what the mitochondria uses in its role as an energy plant. So as a power plant. So that's what we use to convert our ADP to ATP. And this is the canary in the mine. It is affected very early on, anytime there is a change in the reactive oxygen species. So you'll see this affected long before other more anatomical or functional, I'll show you some examples, parameters we measure usually are affected. Okay, so let's dig into this. This has been known for a long time as something you can measure with tritiated compounds in cells, but in dead people. The idea here was to do this in vivo in living humans. So we labeled the triphenylphosphonium with F18, and then we set out to measure that membrane potential, which would be basically if you had a nanoelectrode inside the cell and one outside the cell, that would be the voltage difference you would see. That's what we're trying to measure. I'll spare you the kinetic modeling, which is what a lot of us spend our time doing. But I wanna just point out that what you're measuring here is the voltage in millivolts, not arbitrary units. That was published in 2020, and here's some of the applications. The one I'll show you, obviously, is the one that has to do with cancer. So what we'll look at is cardiotoxicity, but before we go there, I would like to show you this graph to show you that the membrane potential measurement is incredibly well preserved in humans. And rightfully so, because it's, as I told you, the canary in the mine. So this is very valuable because that means that when we're going to set out to imaging that in patients versus healthy controls, the difference will be due to the disease, not to variability in the patients. Because this is many, many patients that were scanned, and you can see that they're plotted here, and they're all about the same. All right, so cardiotoxicity, why are we doing this? As you know, patients who receive doxorubicin in breast cancer, for example, they have serious side effects that not always manifest immediately. Sometimes it's months and years later. And these can be very healthy, otherwise, patients. So there's very little in terms of prediction of who's gonna go for cell death and heart failure or doxorubicin versus who's not going to. One of the measurements we do is the left ventricle ejection fraction, but that's a little bit late. By the time you see the ejection fraction changing, a lot of the harm has been done. And I'll show you in the experimental model that that's the case. So the idea here is there a way we could predict long before ejection fraction has started to telling us there's something wrong, that, is too late? All right, and that's where we would like to intervene with membrane potential PET imaging. All right, let's see. First, I'm going to show you some acute examples because in physiology, you always have to show effect in real time before we go to more long-term, and then I'll show you the chronic model. So in the acute model, these are pigs that are, I'm showing here results in 8 pigs. They're, we have an intervention, we go into the LAD, we inject acutely doxorubicin in the LAD, and we expect to see a drop in the membrane potential transiently in the anterolateral wall, in the anterior wall and septal wall, but not in the inferior wall, because we didn't inject anything in the right circumflex. So the right circumflex serves as the control in each animal, and you should see in this area a drop in the membrane potential in millivolts, and this area no drop, and that's exactly what you see. All right, that's the chronic model. And when we form the images of these, again, these units here are in millivolts. You see minus 120 millivolt, and in the anterior and septal, there is a drop, but in the inferior wall, there's none. Then we move to the chronic setting. That's the more complicated study. Now we're treating pigs as patients who have a breast cancer over several months. And the figure I would like you to leave, if there's one figure to leave for cardiotoxicity with, is this. This is the membrane potential of those pigs over time, and you can see that this was before treatment. You see how it drops very quickly, whereas the left ventricle ejection fraction stays on for a while before it drops. What is interesting is that when we stop treatment, the left ventricle ejection fraction goes up again very quickly, whereas with the membrane potential goes up quickly, whereas the ejection fraction doesn't. So this is a canary in the mine that allows you, in this case, after 6 cycles, to determine where you are in terms of viability of the tissue. And this is a study that we will be starting here at Yale next month. All right, in the last part of my talk, I would like to cover some of the, again, more exploratory in imaging immune response with PET. And we're going to start with ferraheme, which is an MR contrast agent. That's ferromoxetol. It's an iron particle that is actually FDA approved for anemia because over time, the bioavailable iron, the nanoparticle core dissolves and the bioavailable iron becomes exposed, and that's a treatment for anemia that is approved. But it started as an MR contrast, and there have been several clinical trials done in that space because it will track lymph nodes, and you can see lymph node involvement. The only problem is, because it's an MR contrast, you have a few minutes to see it. And after 10, 15 minutes, the signal is gone. So the idea was, well, if we labeled this, and in this case, I'll spare you the radiochemistry, but it's basically a chelation where you heat the core, and then the zirconium-89 goes into the core of the ferromoxetol and stays there forever. If we label that, we could follow then for a long time that compound as it distributes in the body. And this is where we were very, very surprised. This is an example in an animal that had a skin lesion. This is a non-human primate, where now you see the time is 200 hours. We're following for a long time because zirconium-89 allows you to follow the animal. You can see that the uptake in the ipsilateral lymph nodes was going up over time. But there is no circulating activity anymore. The activity after a few minutes has distributed, and that's it. So this is not circulating activity. This is active trafficking of monocytes. And that was our first discovery in this, totally serendipitously, because we didn't expect to see that over time. So I'll show you now another example of what we can do with this. Those of you old enough to know white blood cell imaging, indium white blood cell, remember how we draw bloods and then you label indium. And well, this is a spin on that, no pun intended. But now we draw the blood and then we isolate by by FACS the T cells and the B cells, and we can isolate the monocytes also by buffy coat extraction. And then you label those B cells or T cells with the zirconium ferraheme, and then you re-inject them. And now what you see is this is an EAE model where we're labeling the B cells, and you can see that when you have EAE induction, you do see uptake in the area of lesion, whereas when you don't have the EAE model, when you have a sham induction without labeling of the B cells, you don't see uptake in that area. And the same with the immunomodulator with the T cells. You see that with the immunomodulator, you have a drop when you're doing the T cells, whereas when you're doing the sham or NP injection, you don't see that drop. So this is to pique your curiosity about what you could do now, imaging T cells and B cells in the body, as opposed to, and you can see if they're going to the spleen, well, nothing's happening, or they're going to the tumor, well, that's real immune recruitment. This is a compound that we hope to bring to man here at Yale. It is part of a large study where we've done now the dosimetry. It is all very promising. Radiochemistry purity is also very good. And we're hoping that, within a year from now, this will be in humans here with an IND. All right. I'd like to close. I have still a few minutes. I'd like to close with the pièce de résistance, which is theranostics and the role of PET and SPECT in there. So for those of you who don't know theranostics, the idea is that, said in words, you could see what you treat and you could treat what you see. It is something that we don't often have the luxury of with chemotherapy, where you don't see what you're treating. You treat and then you're treating blind. So the idea basically is that we would use a PET agent, and we'll talk in a minute what agents, but that is going specifically to a tumor to see if you have enough signal to justify a treatment through a radiopharmaceutical treatment. If you do, then you have your radiopharmaceutical treatment, and Pam is doing a lot of this in NET. And then at the end, you could even image and see how well have you done. That's the general idea. What we're interested in doing, and we're very excited, that's another project that will be starting, is that what you could do is not just do your pre-treatment, in this case, lutetium, and Pam told me we've just done our first alpha last week. But for both of them, it's the same idea. You don't do your pre-treatment imaging. You say, yes, there's enough uptake. Well, and then we do our post-treatment. We've done well. What we would like to do is, after every treatment, image the patient to define how our targets are responding, what is our pharmacokinetics, and what is our effective dose. Because there are some patients where we will need to treat more. And there are some patients where we don't need at all the dose we're doing. We can go a lot lower and we still have the same effect. We have an opportunity to do what we've done always in iodine, for example, 131, to do a dosimetry on the fly as the patients are being given their 200 millicurie of lutetium. And there's no cost to it other than the imaging piece, because they are having their lutetium anyway. So that's the idea with NET, with the neuroendocrine tumors. You can do the same, and you can refine this at every treatment. So you can see cycle 1, cycle 2, and then you decide, well, we can stop now. Or no, we're going to have to go one more cycle, as opposed to 6 cycles of 200 millicuries. You can do the same in prostate with the prostate-specific membrane antigen that we can image. We can do a gallium pre, and then we can look at those targets. What's the effective dose? Do we need to go up or down? And do that 1, 2 cycles, and then stop. We can even go further. What we can do, actually, and this is the project that I said we're excited we're starting, is we could do pre-imaging therapy and only have 1 or 2 of those scans, and that is enough to predict, whether you should increase or decrease your dose, and predict your outcome from very few of those studies. You don't need the whole study to predict that. So the idea is going to be to looking at the very early very early treatments to predict that, because more often than not, it is something you can predict. It is challenging. It's not simple, but I think it's very valuable, because When we talk about personalized medicine, this is personalized medicine par excellence. This is like, you can't go more personalized than that. It is your scan that is defining your dose. I would like to leave you with two last slides on something that is a lot more, also coming down. This is work from Jason Kai, who's looking at a similar approach for theranostics, but for gliomas. And this is looking at PARP. Those of you who work in PARP, you probably know that PARP1 inhibitors are approved as treatment drugs in many cancers, breast, pancreatic, but also in brain. And the idea here is to label the PARP and see if we can then use it for treatment. What Jason has done is the very first PARP brain penetrant tracer. There has been some that were not brain penetrant. Why that is important? Because if it's not brain penetrant, then you can't cross the blood-brain barrier, and the only time you see the tumor is when there's breakage. In this case, he has shown that in the intact brain barrier, you can image that and see the tumor. And the idea, of course, is now, he's done that first with C11 because that's the easiest. Now we're doing it with F18, and his plan is to do that with astatine because then you can do the same story we talked about with neuroendocrine and with prostate. Now you can do that in the brain. So that would be a first. And it's optimistic, but he's hoping that in a year or two from now, his IND will be up and running. All right, so I was asked to finish with enough time for questions. I hope this gave you a good sense of what can PET-NMR do for you. I do hope, it gives you some appetite for some of the imaging. I do believe that imaging is not meant to be just, show and tell, but it has to guide the treatment. If imaging doesn't guide treatment, for me, it's, a very, frustrating. It's a nice exercise, but when we can guide treatment, that's when we have a role that is meaningful. So with that, I'd like to thank you for the kind invite to be here. And if you have any questions, happy to take them.
Questions from the room? And yes, go ahead.
Talk about a lot of things. I was curious, what of the things you talked about, where do you think where's the lowest hanging fruit? What do you think of this as the kind of most immediate potential to impact cancer care?
Do you want to come back?
What are you most excited about?
And I hate this question because each of those is one of my kids, and whichever I'm going to say, a lot of others are going to be upset. But I do think that in the theranostic space, there's a lot of room. I don't want to sound pessimistic. We are behind the eight ball here. Most sites have already now very active theranostic sites, centers that are treating regularly hundreds of patients. That's one area of there's clear opportunity. I understand some of the caution of, a lot of these patients recur, and that's right. But it is you saw that example where, we learned by doing something, we realized, oh my God, there's monocytes being trafficked. You're not going to do the alpha treatments, and you're not going to do the second generation if you don't have a site where you're doing a lot of those patients. So it is one area clearly where there is a huge impact for our patients. I understand for now it's only 2 cancers, not every cancer. But again, if you don't have it for 2, you're not going to have it for 10. The other area I would say is the spectroscopy part, because that is now very mature. And for the longest time, we didn't do it because it was too prohibitive in terms of imaging. If you need, 30 minutes to scan in addition to everything you do in an MR, nobody's going to agree to it because the slots are what they are. But 8 minutes is feasible, and I think there's a role there. And I would say guiding the treatment is something that is very important because in no way it is meant to be, oh, well, no, you got it wrong. It is that a lot of times we don't see on the images as much as we should be. So I think the treatment guidance is one area that is promising. Good. That's right. So we do know that they are affected actually, because, you know, if it's Farahim, you know, once it breaks down, it will be taken out in anemia. But that core is not, in the case of Farahim, that core is not broken for over 400 hours. So as long as we're imaging within the area, the time that we have validated our radio tracer, we are safe. What you can't assume, and to be clear, what you're injecting is picomolars. So from a physiological point of view, you're not going to see any effect. It's just that your image after a while will not represent the membrane potential or the monocyte trafficking. It's just taking up wherever there's iron need. It's just over 250 hours later. So that's where we would worry about it, but not within the imaging time. Right. So we have there what we have done, and for the membrane potential compound, I think I showed you some human studies. We have an IND we've done first in human. We've done over 30 of them now. We have done retest in multiple patients on different days. And that's the curve I showed you. And I thank you, Harriet, for pointing this out. That's the curve I showed you where I said it's very constant. This was surprising for us because, you know, there is big variability when we do humans on different days. It is just that this is such a tightly regulated physiological parameter that there was very little change. So we've tested that, but I mean, it's indirectly, obviously, but we've done that in retest. And even when we did patients, well, for now, the chronic is in pigs. When we did pigs over time, I showed you 8 of those that have gone for 6 months. The areas that were not, when we first did the acute, the areas that were not affected on multiple times, that was the same. So that was reliable. Obviously, when we did the chronic, then the whole heart, then myocardium was affected because this is systematic IV injection.
So you're aware that all these novel CDAs various places. If you bring into the imaging
Yes. I would say yes. So thank you. That's not good. Another nice plugin. So we have a PET-MR coming in. Let me, I did mine on. We have a PET-MR coming in Q3 2026 on the, so I know it sounds long from now, but I'm told, you know, in Yale timelines, that's very fast. I've been here 11 months, so I've learned enough now. So this is a research scanner that we are working hard on making one day available for clinical work. The same way we have a 7 Tesla coming in, we have now the agreement that 2 days a week will be available for clinical. I'm very keen on sharing these because the 7 Tesla will be 2 days for clinical. So I hope we'll be able to do the same on the PET-MR side because I'm putting my money where my mouth is. I mean, what's the point of doing all this if you can't see it? The idea being that, you know, if we do 1 day a week and we see a huge value, like you're saying, well, then that will give us the argument for having more of those installed clinically. That's how we've done at Mass General before. We started with a research one, and then at one point, surgeons refused to go in unless they had the PET and the MR. And it was like, okay, well, now we're going to have one clinical.
Can I ask a question?
Of course.
So a question as it relates to quantitative imaging for clinical trials. So I think as we're getting better and better resolution, especially with the sort of PET MR, we're really stuck as it relates to quantitative imaging, especially as it relates to even our new theranostic trials, where we have to use RECIST, which is based just on cross-sectional imaging. Do you have any thoughts on sort of the evolution of that field and where we should be going?
Yes, I think resist is a heresy in the age of the theranostics, because what you're measuring is, if you think ejection fraction is too late compared to membrane potential for the canary in the mine, this is, that tumor is not going to shrink for months before. I mean, this is not at all useful. What I showed in the case of the NET and prostate is a full model, a full dosimetry. We can do that now. The challenge is that currently, if we were to do this, I mean, Larry would love to do this every day, but on his SPECT scanner, it would take him an hour and a half, an hour to do that full survey. But there are scanners available today that are full ring SPECT systems where you can do in 10 minutes what you would do in an hour and a half. And we also are planning on installing one, and we're hoping that will be one also on the clinical side. And there, what you do is just a simple survey, a 10, 20-minute, but every time. And as you do that, then you can see your residency time of your tracer. You can quantify your effective dose, which is a lot more. I mean, that's what people have been doing for ages in iodine I-131 when they needed to quantify how much can you give somebody who's coming back after recurrence. There's nothing there. I wish I could say, oh, this is groundbreaking and very novel. This is standard, and we can do it tomorrow if we had
We just
a
need
scanner.
clinical trial to catch up.
Correct. Oh, absolutely. So this is available, legiferated, I mean, there's nothing there that is very novel. It is just that for most trials, we just cut corner and say, yeah, let's look at resist, but it's there, it's available. And we can do it. And in the PET Center, we can do that for any of those trials.
Question about AI, which you talked a little bit about. In lung cancer, for example, there's a Sybil, which is a way of using AI to look at low-dose screening, and sometimes it's more effective than our current methods. So, and you talked a little bit about, standardizing and the different.
The inter-observer variability, yes.
It's going to go? Is it something where AI is going to help be more accurate, be more better? Is it going to actually be able to replace some of those radiologists so that you can get to, different places in rural communities? Where do you think AI is going to?
I was recently at a talk in surgery, don't ask why, but it's a surgery talk, for a surgeon who only does surgery. In the middle of the talk, he's like, and here's my slide for AI because you have to have one. And I was like, wow, if surgery is now in, then we're good. I think it's not a question of if, it's a question of when. It's happening. AI is taking over a lot of what we're doing. The reason why you notice I'm very careful in what I'm showing is because we are doing a lot of deep learning, and there are what we call cases of hallucination, where every now and then you get a case that doesn't make any sense. And our biggest worry is that, and this is why I was very careful saying this is an aid as somebody's starting to use. The big worry from many of the ethicists right now is that as the physician relies more and more on the tool, they become more and more deferent to the tool. And when sometimes they feel like, oh, I'm not sure, but think that it must be true. And you're still liable. You're still responsible. So I would have a word of caution that, yes, it is happening, but I don't see it as the panacea, because until we have such volumes of data, which we don't have today, that any case we're going to see has been seen before. I'm sorry, I'm not as enthusiastic as I was about everything else I talked about, but that's because we do a lot of deep learning we do a lot of it, and we see limitations. So because of the limited data we have, we don't have the data that Facebook has. We don't have 1 billion PETs. I mean, we don't have 1 billion CTs, let alone 1 billion PETs.
We probably need to end. If others have questions, maybe come up afterwards, but we're at time. But thank